Don't know me. My name is Simeon Mitchell. I'm a fourth-year Emerge resident, and I'm also this year's EMS fellow. And so I'm going to talk to you today about cardiac arrest centers and whether or not we need one here in Ottawa. Before I get started, I just wanted to acknowledge a few people that helped me with my grand rounds. So special thanks to Dr. Dion and Dr. Maloney for being my supervisors and also for all their insights into this topic. I'd also like to thank Jason Lewis and Susan Duncan from the RPPO quality team that shared some Ottawa cardiac arrest data with me. And then finally, I want to thank a number of different people. So Juan Russo from cardiology, Brock Wilson from ICU, and then George Mastoros and Andy Pan from the emergency department, who also shared some of their thoughts. So our objectives today are to review the current Code ROSC protocol, that we have here at TOH and discuss a little bit about how that works in the field and also in the hospital. We're going to discuss the evidence for cardiac arrest centers and also their individual components. And finally, we're going to explore some of the future directions for cardiac arrest care here in Ottawa. While we go through this presentation, there are a couple of themes that I want everybody to try to keep in mind that will help frame some of the things that I present in the talk. So the first is that geography is destiny, and the concept that where the patient ends up will actually influence some of their downstream care. The other one is system-level thinking, so trying to figure out on a system level how the system functions as a whole and what we can do to try to help improve patient outcomes. And finally, leadership, and I think that being in the emergency department, this is kind of our territory or turf, and I think we have a lot of things to offer to help improve cardiac arrest care. So let's start by reviewing the current system that we have here in Ottawa. And let's first look at the VSA protocol that the paramedics are using in the field. So these are the interventions that advanced care paramedics can do in the field. Of note to maybe some people, now in Ottawa, all the first response cars have the Lucas device, so they can do mechanical compressions with that. And then they have the full gamut of basically ACLS interventions. So you can do defibrillation, antiarrhythmics with lidocaine, fluids, a supraglottic airway, and intubation. There's this mandatory patch point, and this is put in by the Ministry of Health looking at the patient care standards. And so all paramedics will patch after their third analyze or after their third epi dose, and that's a mandatory patch point to basically ask for advice as to what to do next. There are a few exceptions to this rule. So the ALS PCS talks about exceptional circumstances such as some drug overdoses where you could proceed to the closest hospital after one analyze. And then they also say for hypothermia and any kind of airway obstruction that you can't relieve, you should go to the closest emergency department right away. We also have a pre-hospital ROSC protocol as well. And so the targets that the paramedics are targeting in the field is the systolic pressure greater than or equal to 90, an oxygen saturation greater than or equal to 94, and an entitled CO2 of 35 to 40. The assessments that they do on all ROSC patients is a 12-lead ECG in the field to determine if the patient has a STEMI. And then the interventions that they have available to help optimize some of these targets are fluids and also dopamine. If the paramedics get ROSC in the field, the current protocol is that they should go to the nearest hospital. I'll quickly go through a little bit about how the Code ROSC process works at TOH, but I think for most people in the room are very familiar with this. So this is a poster that I could find. It's maybe a little bit out of date because there's a lot of mention about therapeutic hypothermia, which we'll talk about. So as you know, if there's a ROSC patient that comes in, the idea is to do a 12-lead ECG, and then if there's a STEMI, the person goes to the cath lab. If not, and there's a suspicion that it's a cardiac etiology, the idea is to get ICU and cardiology to talk about this. I'm sure some people have had some different experiences with this, especially different experiences at different campuses. So from talking to a lot of different people, it seems that this works fairly well at the Civic, but at the General, where there's not always access to a cardiology fellow, this is sometimes a bit more of a challenging process. We used to have therapeutic hypothermia orders, which we are no longer using because of the new 2015 guidelines. And so now what we're doing in the ICU is just writing orders on a regular order sheet for targeted temperature management. Finally, I sometimes feel like, especially at the general, we sometimes get into these arguments or disagreements about where the best disposition for these patients are, because often there's not a great history. Often there's not a lot of history to suggest if it was a cardiac etiology or not. Sometimes it's very clear, but the vast majority of times it's not, and this can be a challenge to sort out. Let's go through a little bit of the data of out-of-hospital cardiac arrest here in Ottawa. So these are numbers that reflect patients transported by Ottawa Paramedic Service, Renfrew, and Prescott Russell. So this is patients that are going to more than just our centers. And so you can see, on average, in the past 3 years, there have been about 600 out-of-hospital cardiac arrests. You could see that there have been roughly about 200 of those that get ROSC in the field. And we can also see that those numbers that include patients that had initially a shockable rhythm in the field and then got ROSC is around 70 to 90. The number of patients that are transported to the hospital with CPR ongoing is roughly around 120. And then the number of patients that get ROSC in the field that then have a STEMI on their pre-hospital ECG is quite small at around 10 to 20. This graph shows survival to discharge across all of the RPPEO, so this includes all of Eastern Ontario. You can see on this line here, this is basically all the patients combined, and you can see that the survival has basically stagnated at roughly 10%. If we look at some of the lines above, you can see these are more specific subsets of patients. So this line includes patients that had a shockable rhythm, and patients that it was witnessed by a bystander, and you can see that then the survival increases quite a bit to around 37%. If we add in bystander CPR as well, you can see that this increases to about 40%. Again, these numbers have roughly remained stable with time. So the first part of this presentation is I'd like to talk a little bit about ROSC and return of spontaneous circulation. So we'll start with a case. So you're working overnight at the general, and the nurse comes and tells you that there's a patch that's 5 minutes out, and it's a 50-year-old man with ROSC in the field. There's no past medical history. It sounds like it was a sudden collapse. The initial rhythm was VFib. It was a witnessed arrest. No bystander CPR was performed. The patient was defibrillated twice, and they have ROSC in the field. A 12 lead done by EMS shows that there's no STEMI. And the vital signs are a heart rate of 100, a blood pressure of 90/60. The SATs are 100. The patient is apneic when they're not being bagged, GCS of 3, and there's a supraglottic airway in situ. So my questions to you are, what will you optimize when this patient arrives at the general? And the other thing that I want people to think about is, do you think that the general is the most appropriate destination for this patient? So we can't talk about ROSC without reviewing a little bit about post-cardiac arrest syndrome. And so this is the syndrome that you get after cardiac arrest, so whole body ischemia and then reperfusion. And so this has a number of different components. There are 4 components. The first is the unresolved reason as to why the person had the arrest. And then there's a few other components that people get no matter what was the etiology of the arrest. And so this includes brain injury, this includes myocardial dysfunction, and this includes systemic ischemia and then reperfusion. So the pillars that the AHA recommends for ROSC care are all about trying to undo these effects that you get from this syndrome. And so these include cardiovascular care. So this includes PCI, and we're going to talk about this in more detail. It also includes hemodynamic targets, and so the targets that the AHA recommends is a systolic pressure greater than or equal to 90 or a MAP greater than or equal to 65. It also includes targeted temperature management, and this was a change in the 2015 guidelines. And so the current guidelines are that you maintain a temperature of 32 to 36 degrees Celsius for 24 hours. This kind of came about after a number of trials, but perhaps the biggest one was in 2013 by Nielsen et al., which showed that cooling at 33 compared to 36 was not superior. I'm not going to spend a lot of time talking about targeted temperature management because this is almost a topic in and of itself. Finally, there's some elements of respiratory care. So the idea is to maintain an oxygenation of greater than or equal to 94 and a normal PCO2. And then finally, there's neurologic care. So treating seizures and prognostication. And the recommendation is not to do any sort of prognostication until 72 hours after the patient returns to a normal body temperature. So if we look at the 2015 guidelines and specifically look at what the 2015 guidelines say about cardiac arrest centers, you can see that both the AHA and the ERC have guidelines about this. And we're again interested in this last part of the chain of survival, so the post-resuscitation, or post-ROSC care. And so you can see that the AHA says that there's not great evidence for a regionalized approach to out-of-hospital cardiac arrest, but it may be considered. And they say that this is based on weak evidence with limited data. The ERC has a little bit of a more wishy-washy language, and they say that specialist care may be effective, and even though there's not great evidence, probably a lot of people are going to do this anyway. And so a lot of this relates to the timeline of studies that have been done surrounding ROSC centers. And so there's a date which is important, which is 2015, which is when the most recent ILCOR and AHA ERC guidelines came out. Before that, there were many, many studies, about 20, and they were all often talking about ROSC centers in the context of therapeutic hypothermia and very aggressive cooling targets. And so the idea was that to cool people to this degree, it had to be very invasive, and they had to go to a specific center to have that done. In 2015, the new guidelines came out, and since there have been only about 5 studies that have, again, looked at ROSC centers, and now the focus isn't so much just on therapeutic hypothermia. And we're going to talk about some of these studies in a little bit more detail. The first study that I want to talk about was published in Resuscitation in 2016 by Schober et al. And so this was a study that was done in Austria, in Vienna, and this had about 800 patients, and it was done between 2013 and 2015. And what they were doing was looking at the survival and how that related to the number of VSA patients admitted to a hospital per year. And so they were dividing patients up into low-frequency centers, medium-frequency centers, and high-frequency centers. Of note, if you would look at our center, based on the volumes, it's probably in the low-frequency center. And they were trying to see if the number of patients admitted per year had any impact on survival. This was a retrospective study. And so what they found is that if you were admitted to a high-frequency center, you had an odds ratio of around 5 for survival, but more specifically, survival with a good neurologic outcome. So what the CPC means is it's the cerebral performance category, and it's basically like the modified Rankin scale. It's a scale that has to do with disability, and so a score of 1 and 2 basically means functionally independent. So this study found that if you're admitted to a high-frequency center, you had a better survival and also a more functionally independent outcome. If you look at their Kaplan-Meier curve, you can see that there's quite a bit of difference in the survival, and you can see that this starts to become apparent after around day 5 of admission. Another study that I wanted to talk about is a ROC study. So this was published in Resuscitation in 2015. And so this was a retrospective study that used the ROC PriMed population. So if you recall, this was the pre-hospital resuscitation using an impedance valve and early versus delayed analysis. And so this was done between 2007 and 2009. And so what they did in this study was try to look at how hospitals follow the guidelines, the AHA guidelines, with regards to these 3 factors. So with regards to coronary angiography within 24 hours, targeted temperature management, and no early prognostication. And they wanted to see if that influenced survival. And so what they did is they divided all of the hospitals up into quartiles. So if you were in the 4th quartile, it means that your hospital followed all those guidelines very, very effectively. If you were in the lowest quartile, so the 1st quartile, your hospital didn't follow those quite as much. And you can see that there's quite a big difference in terms of survival. So the more your hospital followed those guidelines, the better the survival benefit. And again, that led to survival with functional independence. This is a graph showing those same results, and you can see that those results are more specific to shockable rhythms. So it's a more clear delineation with shockable rhythms, with VT and VF, and a little bit less clear with PA or asystole. Again, the limitations of these studies is that they're both retrospective. There was recently a study published in Resuscitation in this year, and this is exciting because it's finally an RCT looking at this issue. The issue is that it's a pilot study, and so hopefully they're going to publish the bigger RCT soon, which will hopefully shed light on this. But this was the feasibility study, and the population that they're looking at is out-of-hospital cardiac arrest of patients with VF, so who had a shockable rhythm, who do not have a STEMI, and they're being randomized to ROSC centers or the closest hospital, and they're seeing if this has any day on both mortality and any day on neurologic performance and major cardiovascular, cerebrovascular events. And so we're hoping to see the results of this in the coming years. I can't talk about cardiac arrest centers without talking about PCI, because this is really central to cardiac arrest centers. And we know that there's a lot of very clear guidelines what to do if the patient has a STEMI, and that's very easy. They go to the cath lab. Where it's not quite as clear as what to do with these people that have a shockable rhythm and have ROSC but do not have a STEMI on their ECG. And so the AHA guidelines for this say that it's reasonable to do an emergency cath, but they say only really if people are electrically or hemodynamically unstable. So again, it doesn't really provide us with very clear delineation of exactly what to do. We also know that if you do coronary angiography, there's a few benefits. So we know that in studies that have been done in the past, they've identified culprit lesions in around like 60 to 70% of people with out-of-hospital cardiac arrest without a clear non-cardiac etiology. We also know that the ECG and biomarkers have a very poor sensitivity in the setting of cardiac arrest and ROSC, and one study showed that the ECG was only 42% sensitive for an acute MI. And finally, we know that there's some other interventions that you can do in the cath lab. So those include putting in a balloon pump, putting in these invasive cooling catheters, and also assessing LV function. So I want to go through two studies that looked at doing cath in the setting of patients without ST elevations. One of those is the study by Hollenbach et al. And so this was done in Resuscitation in 2014. This involved 269 patients, all who had VF or VT arrests, and this was done in the States. This was, again, a retrospective study, and what they looked at was the difference between doing an early cath versus a late cath. The way they defined an early cath was doing a cath on arrival or upon the initiation of therapeutic hypothermia, and a late cath implied any time during their admission. And so the primary outcome was survival to hospital discharge, and their secondary outcomes was neurologic outcome and LV function. If we look at a modified results table, you can see that early cath had a survival benefit, so the patients that did not get an early cath had greater mortality. You can see that, again, the people that got an earlier cath were more likely, to have a functionally independent outcome. And then you could see that there was a trend towards better LV function in the people that got a cath, which was not statistically significant. And I'll just point out, in this context, there's quite a big difference from talking to some of the people that I spoke with in preparation for my grand rounds between the number of patients that get a cath if you happen to end up at the Civic or you happen to end up at the General. And there definitely seems to be a certain amount of roadblocks or difficulty in getting a patient a cath at the general once they're admitted to the intensive care unit. The last study that I'm going to go through on this topic was published in JAMA Cardiology. And so this was a very large database study, which was done using a USA database. And this had over 400,000 patients, again with VF and VT arrests from the early 2000s to 2012. And again, they were looking at a few trends in PCI in this patient population. So they found that, first of all, the use of PCI in this patient population has increased from around 19% to 33%. The survival to discharge has also increased in this patient population from around 43% to 56%. And that having a cath had an odds ratio of around 6 for survival to discharge. If we look a little bit about our own data and the distribution of where these patients are going, so this graph is looking at patients that get ROSC in the field that have an initially shockable rhythm. We can see that they're fairly spread out if they're going to the Civic, the General, Montfort, or the Queensway. And this is because, again, the protocol is that EMS will take them to the closest hospital. If we phrase these numbers in a different way, this is the same data, but just for 2015. I'm sorry that I don't have any 2016 data, but that isn't yet available. If we look at this 2015 data, you can see that there's about 20 patients between the General, another 20 patients at Montfort, and another 20 patients at the Queensway. And so what I propose to you is actually these groups of patients should actually go to the Civic. And so this would correspond to an increase of about 53 patients a year, 4 patients a month, or 1 patient a week, which I don't think is a huge increase in volume, and I'd be very curious to hear some people's thoughts after in the discussion about this. You might be thinking, well, we're going to take these ROSC patients that are potentially quite sick, and then they're going to be driving with EMS in the ambulance. This is a very sick population of patients. Is that a safe practice to do? And indeed, we know that the rearrest rate on transport, so this is from the scene to the hospital in patients that have had a VF or VT arrest, the rearrest rate is around 18%, so close to 20%, and this was done in a ROC study. But there have been some other studies that looked at transport bypass in VSA patients, and a number of those studies were actually done by Ottawa authors. So there was a study published in the Annals of Emergency Medicine in 2015. Dr. Steele and Dr. Maloney were both co-authors, and this was looking at the OPAL study and seeing if there was an association between transport time and survival. Again, this is not looking at response time, so this isn't the amount of time it takes for the ambulance to reach the patient. This is once they're going to transport the patient to the hospital, how long that takes. You can see that this was a pretty short transport interval, though, of about 4 minutes. And there was another study that was published in 2008, and this was done in Arizona. And again, they found no association between transport time and survival. And again, there was a fairly quick transport interval. But perhaps the best study looking at this, Dr. Vaillancourt is a co-author, and this was published in 2010. And so this was, again, using ROC data. So that's good because it's Canadian centers and US centers. And it involved a very large number of patients, so about 7,500 patients. And it was done a bit more recently than the other studies from 2005 to 2007. And they found that those taken to further hospitals had actually better survival compared to those taken to closer hospitals, a difference of about 32% to 25%. What's maybe most interesting to us is that patients that had the longest transport interval, so that means greater than 8 kilometers, also had improved survival. Unfortunately, this didn't reach statistical significance, but there was still this benefit towards actually taking the person to a further, more specialized hospital. And so put another way, adding kilometers to the transport interval had an odds ratio of 1, so no difference, and transport to the closest hospital had a survival benefit. I'd like to shift gears a little bit and talk about refractory VF and VT. And so we'll start with another case. And so this is a case where you're working at the general, you answer the patch phone, and the person on the line says this is ACP 123, which is always a little bit concerning. But the story is that there was a 65-year-old man that was found by his wife. The downtime between collapse and EMS arrival is estimated to be about 5 minutes. When EMS arrived, he was in VF. He was shocked 4 times. He's still in VF. They've already given 3 rounds of epi, and they've already given lidocaine. They have an LMA in situ, and the end tidal is 10. He only has a history of hypertension and COPD, and they're about 8 minutes from the Queensway. Again, they're calling you because the protocol says that they have to call at this juncture. So the things that I'd like people to think about a little bit is, what would you tell them to do in this situation? And what do you think is the most appropriate transport destination for this patient? If any, unless you think that you should grant a tour for this patient. So if we look at a little bit our toolbox for refractory VF and VT, we can see that we have a number of different options. So we have regular ACLS, which EMS can provide. We have double sequential defibrillation, which EMS can do if you give them online medical control to do that. But the issue is that you need to have 2 defibrillators, which in the city limits is often possible because usually there's the first response car and a transport ambulance. So actually that's usually feasible in our setting. Beta blockade, which we obviously cannot give pre-hospitally. And then the other options are PCI, but in Ottawa we're only really doing this if we get ROSC, which is a little bit different than if you talk to people in the States where they're actually cathing these people even if they're in arrest. And finally, ECMO. I want to just bring your attention to Amanda Collier's grand rounds that were done recently, which were a very good review about the treatment options for refractory VF, but we're going to talk about some specific things. So both PCI and ECMO, the destination that the patient would be going to is integral to implementing those treatment options. If we look a little bit about ECMO for refractory VF or VT, we know that ECMO is listed now as a treatment modality for refractory cardiac arrest. The AHA guidelines with regards to this in 2015 say that there's not enough evidence to support routine use. And if it's rapidly implemented, it might be useful for certain sub-patient populations, but this is based on very weak data and limited evidence. And then also who's initiating ECMO for these patients is extremely variable. So is it cardiac surgery? Is it physicians in the emergency department? Or is it actually being done in the field? This is a picture from Paris where they placed a patient on ECMO in the Louvre. I'm not at all advocating for this. I don't think this is a good idea. But what I mean to say is they're very extremes, and there's some places where they're treating these patients very, very aggressively. And I'm not saying that we should do this, but maybe we should modify our practice a little bit. If we look a little bit about the number of publications with time for ECMO, you can see that it's been increasing exponentially. And again, I want to also reference Noam Katz's grand rounds about ECMO, but again, we're going to talk about very specific things. You can see that in 2017, it's only March, and already there's almost half the number of publications that were published last year on ECMO. And so if we look at some of the evidence for ECMO in refractory VF or VT, we can say that there's a number of studies that show some promising early results. And so, for example, there was a study done in Japan. They've been very aggressive in using ECMO. And so this was prospective, involving about 400 patients. This was bundled, so it wasn't just ECMO, but it was also therapeutic hypothermia and a balloon pump. And you can see that they had very impressive functionally independent survival on implementing ECMO. If we look at this study, which was done in Australia, the CHEER study, you can see that this was a very small study. This was a combination of out-of-hospital and in-hospital cardiac arrest. But again, their survival rate is quite impressive. again with a functionally independent outcome. And finally, if we look at another Australian study that was done perhaps quite recently in 2017, again, we can see fairly impressive survival with functionally independent outcomes. But what I want to talk about in a little bit more detail is this study that was done in Minnesota that was published in the Journal of the American Heart Association last year. And this is the preliminary results of this new protocol that they released in Minnesota for ECMO. And so the idea was that they were examining the results of the first 3 months of implementation of this trial and this protocol. And this was quite a small study, so there were only 27 patients in this study. But the idea was that they were going to try to get patients in refractory VF or VT essentially to PCI or to the cath lab. And the way that they were going to do that was by implementing LUCAS, so mechanical CPR, followed by ECMO, followed by PCI. Their inclusion criteria that they used, and the idea was that EMS would screen these people for inclusion into this protocol, is quite reasonable. And a lot of the criticisms behind ECMO and a lot of the problems in interpreting ECMO literature is that they've been using very different patient populations between studies, and the inclusion criteria have also been fairly loose. But here, these are probably similar to inclusion criteria that we would use in Ottawa. So again, they're looking to see, there's a criteria based on age. They're looking to make sure that you've already tried shocking the person 3 times. You've already given an antiarrhythmic. It looks like this is probably a cardiac etiology behind this person's arrest. Another inclusion criteria was that you actually had to fit into the LUCAS, so they excluded anybody that would require manual CPR in the ambulance. And finally, that the time from the scene to the cath would be less than 30 minutes. Their exclusion criteria were also very reasonable, so they excluded people that were in a nursing home, they excluded people that were terminally ill, they excluded people with a DNR. If we look at some of their evidence and some of their results, you can see this is from their publication. If you look at the bottom, you can see 911 to CLL, which basically means the cath lab time. And so you can see that this was on average about 60 minutes, which probably if you would try to do something like this in our setting, it would probably be similar to this. So that's kind of interesting. And then if we look at their actual results, you can see that they're fairly impressive. So again, it's a very small study. They only had 27 patients. 9 were excluded because they actually didn't meet their predetermined inclusion criteria. So they had 18 patients transported meeting the inclusion criteria. Of those, 78% survived from the cath lab to hospital admission. And finally, from that, 53% survived to discharge and survived to 1 month. And again, the vast majority, well, not the vast majority, half of these patients had a functionally independent survival as well. If we look at some of the Ottawa data for refractory VF, again, over the past 3 years, again, we don't have the 2016 data yet, you can see that on average there's about 5 or so of these cases per hospital per year. And so if we look at the 2015 data, you can see that there were 5 people that went to the General, 4 people that went to Montfort, and 4 people that went to the Queensway. And so I would propose that these people that have refractory VF or VT should actually go to the Civic. And so this would be about 13 patients a year going to the Civic, or about 1 patient a month. The last part of what I'd like to talk about is hypothermic arrests. Has anyone read this article? So this is a pretty inspiring article, or a very interesting case. So this is the story of a Queen's student who was 21 years old, who had a suicide attempt, and the way he tried to kill himself was by taking basically a bunch of sedatives, and it's unclear entirely from the news article if it was chloral hydrate or a combination of things. And then he went to the Kingston Pier and essentially froze to death. And it sounds like his roommates heard about this in a certain amount of time, and EMS was called. And so when they got there, they transported him to KGH, which luckily enough for him is only about 900 meters away. When he arrived, they found that his core temperature was actually 20 degrees, so 20.8 degrees centigrade. And so the rewarming strategies that they used was warm saline. They tried pleural lavage with chest tubes. He had CPR for over an hour. But what they actually ended up doing is taking this person and putting him on cardiopulmonary bypass, and then finally transitioning him to ECMO. This patient survived, and he's actually now back at Queen's as a student. So it's just a pretty inspirational story as to hypothermic arrests. If we look at some of the tools that we have for rewarming patients that have arrested due to hypothermia, you can see that there's a number of different options. Some of them do not have cardiac support, and some of them do have cardiac support. You can see that the rewarming rate in terms of degrees centigrade per hour, especially as to some of the interventions that we would readily employ or think would have quite a big effect, so like warmed IV fluids, for example, have a pretty variable and a pretty poor rewarming rate, so of around 0.1 to 3.4 degrees centigrade per hour. If we look at some of these more invasive strategies like VA ECMO and cardiac bypass, you can see that the rewarming rates are quite a bit higher, of around 6 to 9 degrees centigrade per hour. So let's look at some of the case reports and some of the evidence surrounding using ECMO to rewarm hypothermic arrests. As I mentioned, they're really just case reports or case series. There's not any good RCTs looking at this patient population, just simply because there are not enough patients. Expert consensus, though, says that VSA patients who have arrested should be rewarmed invasively with cardiopulmonary bypass or ECMO, and this is supported by the AHA. So they last updated their hypothermia suggestions in 2010, and they supported using bypass or ECMO for arrested patients. And if we look at some of the other literature around this is a lot of it comes from this article that was published in the New England Journal of Medicine in 2012 by Brown. And the suggestion there was that these patients should actually be bypassed to a hospital that is capable of instituting bypass or ECMO. I want to show you one study which is interesting because it's been done over a 10-year period. So this is a study out of Edinburgh in the UK. It was published in the Journal of Emergency Medicine in 2016. And what they did here is, again, it's a small number of patients. So it's a single center involving 11 patients over this 10-year period. And you can see that, looking at the flow diagram, that 9 of these patients got bypass, 2 of these patients got ECMO, and you can see that their survival is actually quite impressive. So their survival to discharge is 72%, and their survival neurologically intact is 75%. The mean temp on admission was around 20 degrees centigrade. So if we look at some of the Ottawa data, how many hypothermic arrests are we having in our region per year? You can see that basically for 2013 to 2015, there's been 1 arrest a year. And so, again, I would advocate that these patients should be bypassed to the civic, and this is 1 patient a year that we're talking about. So I have a little bit of a proposal for you as to what some of this might look like in the future. So the first thing that I wanted to show you is the Ottawa ROSC bypass protocol proposal. And so the idea would be that you take patients that have ROSC in the field. Again, you use what's already now part of EMS's protocol in terms of optimizing certain targets and with the interventions that they already have. And then you do a 12-lead ECG. If the 12-lead ECG shows a STEMI, the person goes to the Heart Institute. So this is, again, nothing new. If the person does not have a STEMI, I think that we should divide them up into patients that have had a shockable rhythm in the field and patients that have not had a shockable rhythm in the field. And I would advocate that the patients that have a shockable rhythm in the field should go to the civic. That way they can be rapidly assessed by cardiology, and probably all of these patients should be considered to get a cath. If there's no shockable rhythm, then I think it's reasonable to continue the way the status quo is and transport these patients to the closest hospital. I'd also suggest some possible changes to what we're doing for certain VSA patients. So what I would suggest is patients that have refractory VF or VT, and again, we're defining this as no ROSC despite 3 rounds of defibrillation, epi, and also having lidocaine on board, that first of all, we should consider doing double sequential defibrillation on these patients. And I think that that's, especially in Ottawa, easy enough to implement in the field. But if there's no exclusion criteria present, and we can talk a little bit about what that would be, I think that these patients should be bypassed to the Civic and not go to the closest hospital. Because I would argue that there's not much that the closest hospital is going to be able to offer that EMS cannot offer. And I think really what we need to do is get these patients to the right center where we can do some more invasive strategies, possibly like ECMO. I would say that we should also remove the patch point. I don't really think it makes sense for EMS to be calling us to ask us what to do when we have somebody who's in refractory VF in the city of Ottawa, within the city limits, because I really don't think that we should be, unless there's some specific criteria granting tours on these patients, and these patients are potentially salvageable, and I think that that's just a time-wasting step. I think that we should consider doing the same thing for accidental hypothermia. And so again, if there's an arrest that's presumed to be due to cold weather exposure, I think that these patients, if they do not have any exclusion criteria, should be bypassed to the Civic. And then finally, I think in the future, but not now, we could consider making some other changes. So for example, patients that have a beta blocker overdose or a calcium channel blocker overdose or a very clear history of a PE, maybe these patients should also be bypassed to the Civic. Things that we would need to work out to implement this sort of thing is a little bit as to what is the drive time criteria. So what's a reasonable amount of time for EMS to be driving by closer hospitals? A little bit about what the exclusion criteria are, and I would advocate using something similar to what they used in the Minnesota trial. And then also we would have to figure out what happens once this person gets to the Civic. How are we going to try to make some of these invasive interventions available to this patient? So there's definitely some things that would have to be worked out in this sort of proposal. So going through some take-home points, I think that out-of-hospital cardiac arrest and ROS patients deserve specialized regionalized care. We've started doing this for stroke. We've started doing this for STEMI. I really think that we should start doing this for cardiac arrest patients. An obvious start in terms of trying to figure out how to do this is to start making these modest destination changes in very specific patient populations. And so I think that that would include ROSC patients that have a shockable rhythm in the field and patients that have refractory VF or VT or hypothermia. And finally, I think that the way we're treating patients with out-of-hospital cardiac arrest is going to change dramatically in the next 5 years. And I would say that we should, in a conservative way, start to move in that direction and start to try to implement some system changes, because I think that we have the opportunity to do research on this and to be the leaders in this sort of thing. And these are my references, and I'm happy to take any questions, and I'd love to have a bit of a discussion about this because I know some